everyone, continuing with the pediatric lectures. Today we're going to discuss CML. CML constitutes approximately 3% of the childhood leukemias, and it is myeloid hyperplasia of bone marrow origin along with extramedullary hematopoiesis. There is increase in the number of WBCs up to the mark of greater than 1 lakh, and all type of granulocyte precursors are seen. The marker for CML is, as all of us know, is the Philadelphia chromosome. Now, Philadelphia chromosome, what is the translocation? There is a 9 to 22 chromosomal translocation of a gene. The CABL on 9 translocates to fuse with the BCR on the chromosome 22. The imatinib therapy is based upon this genetic translocation. And ionizing radiation is also a risk factor. So there are two varieties, the adult form and the juvenile form. The adult form is seen greater than 4 years, and the juvenile is seen up from infancy to less than 4 years, and it has a more rapid course. So adult variety constitutes approximately 5% of the cases, and it's rare at the children, and it has three phases: the chronic phase, the accelerated phase, and the blast crisis phase. The chronic phase is the phase at which the diagnosis occurs in most cases, and it has approximately less than 10% of the blast cells, and usually the patient is asymptomatic. The accelerated phase, here they are 10 to 19% of the blast cells, and here we see increased basophils which are responsible for the pruritus. Also we see thrombocytopenia and splenomegaly. In the blast crisis phase, there is uncontrolled proliferation characterized by greater than 20% of the blast cells, and along with it can undergo transformation, in which 2/3 of the cases undergo transformation to the AML, and less than 1/3 go to the transformation to the ALL. The clinical features are non-specific: malaise, weight loss, fatigue, abdominal fullness. Splenomegaly is the most common physical finding. Investigations, you get a CBC done and you will see anemia, thrombocytopenia, but what will be the striking feature is the increase in WBC to greater than 1 lakh. And all type of precursors are seen. As discussed, basophilia is more common in the accelerated phase. Diagnosis is based by the cytogenetics as well as the bone marrow studies. The treatment is imatinib. Usually the dose is 340 mg per meter square per day. If timely started, it can cause complete hematological and cytogenetic resolution, and also decreases the progression to accelerated or blast crisis phase. However, if the patient is diagnosed in the accelerated phase, the survival is less than 1 year, and if diagnosed in the blast crisis phase, the survival is less than 1 month. In patients who are not responsive to the TKI, the treatment is just stem cell transplantation. Usually, the response to imatinib is the most important prognostic factor in CML. The new drugs that have come are the dasatinib and the nilotinib. What prognostic scores these are usually used in adults? They are the Sokal score and the UTOS score. The Sokal score includes the spleen size, age, percentage blast cells, and platelet count, whereas the UTOS is more simplified and includes only the spleen size and percentage basophils. Thank you. Hope you like this lecture. Until next time, bye bye.